Noble sir, I'd like you to stay back, please. You are chairing the next session also. Next, I'd like to invite Dr. Edwin Fernando, sir, Professor and Head of Department Nephrology from Government Stanley Medical College, Chennai. Thank you, sir, for being part of this event and giving us the opportunity to learn from us. Next is Long Case 2 being presented by Dr. Praveen Kumar.
Good morning, sir. So today's case presentation, our case is a 64-year-old male who's hailing from Senur, educated up to 10th standard, a retired VAO by profession, has come for his scheduled maintenance hemodialysis session. History was obtained from the patient himself and his son. History of presenting illness. The history dates back to 2018 when the patient was 58-year-old, when the patient had blurring of vision, for which he consulted a local ophthalmologist. So the history dates back to 2018 when the patient was 58-year-old, when the patient had blurring of vision, for which he consulted a local ophthalmologist. He was told to have cataract in both his eyes, and he was operated for the same. During the admission for the same, he was informed that he has diabetes and hypertension, for which he was initiated on drugs. And he was also told that there is some problem in his eyes due to diabetes. The patient was discharged with the drugs, for which he was non-compliant since then. There was no history of proteinuria, no history of pedal edema, no history of reduced urine output at that point of time. In 2023, when the patient was 63-year-old, the patient had giddiness and swelling of both his lower limbs halfway up to his legs, for which he consulted a private practitioner. He was found to have high sugar levels and elevated blood pressure at that point of time. His blood and urine investigation revealed that he had some problem with his kidneys in the form of elevated creatinine. His son remembers it to be around 3 milligrams, and he had a protein leak in his urine. He was advised to be compliant to his medications at that point of time, and he was discharged with medications. On probing further, the patient actually gives history of on and off leg swelling before this particular admission. There was history of proteinuria. There was no history of hematuria or reduced urine output. No history of fever, dysuria, or loin pain. No history of NSAID use, over-the-counter medications intake or CAM intake. No history of renal stone disease before this. No history of any hearing difficulty. No history of renal disease in his childhood. And history of occasional numbness of his left foot while walking. In June 2024, 8 months back, the patient had a sudden onset chest pain and breathlessness, for which he was admitted in emergency in CMC Vellore. During this admission, he underwent angio and was found to have 5 blocks in his heart vessels, and he was told that he needs an urgent surgery. So the patient underwent bypass surgery at this point of time. He was in ICU post-surgery, during which his son was informed that the patient's renal function is deteriorating and his urine output has started to reduce, and that patient needs dialysis initiation. He was initiated on hemodialysis via right IJV tunnel catheter. The patient continued to require dialysis throughout his hospital stay of around 1 month. He was in the ICU for 2 weeks and then transferred to ward. During discharge, the patient continued to remain dialysis dependent, and his family was informed that he might require continuation of maintenance hemodialysis. The patient says that during his hospital admission, he developed weakness of his bilateral lower limbs from the time of shifting from ICU to the ward, and he had difficulty in walking ever since. So during discharge itself, the patient required assistance of wheelchair to go to his home. Since then, for the past 8 months, the patient has been having difficulty of walking, that he requires only wheelchair, and he has to be carried from the car to the wheelchair every time he comes to the dialysis session. However, the patient says that he was able to perceive all sensations, and he assures continence of his bowel and bladder. He requires wheelchair for mobilizing and resorts to using diaper and bedpan for toilet purposes. He has been evaluated for the same, but since no clear diagnosis was obtained, or he was not aware of that, and he has been undergoing for regular physiotherapy for the same ever since. There was no history of any trauma or any back pain at any point of time. The patient continues to be on thrice weekly maintenance hemodialysis since 2024 July, with a dialysis vintage of 7 months, and the access being right IJV tunnel catheter. He has an average interdialytic weight gain of around 1.5 to 2 kg. He notices that his urine output has gradually reduced to 300 to 400 ml per day at this point of time. There was no history of intradialytic hypertension or hypotension. There was no history of any emergency admissions. There was no history of blood transfusion. However, the patient was not aware if he was transfused blood when he was in the ICU during CABG surgery. He remembers that he was given 10 weekly doses of iron injections. He was said that it is to improve his blood, and he is currently taking a subcutaneous injection for maintaining his blood levels during every session of hemodialysis. He does not remember being vaccinated for hepatitis B. His current dry weight is 54.5 kg. He does not have any fever during his dialysis sessions. An AV fistula was created in his left distal forearm 1 month back. There are no live donor prospects not registered for deceased donor renal transplantation. He is brought to hemodialysis by his son-in-law or daughter-in-law, and the patient has come currently for his regular hemodialysis session without any complaints. Past medical history.
Really considering him for transplant, 64-year-old bed-bound, wheelchair-bound person.
Past medical history. In 1992, the patient had bleeding PR and mass protruding per annum. He was diagnosed to have hemorrhoids and underwent surgery for the same. He underwent cataract surgery in 2018 and was on medications for diabetes, hypertension, and his heart issues since the CABG surgery. There was no history of tuberculosis, bronchial asthma, or epilepsy for this patient. Personal history. Patient consumes mixed diet. He is not a smoker. He resorts to alcohol use since 20 years of age, but he says that it's just once or twice in a week and rarely, not a continuous pattern. He was married at 26 years of age and son and a daughter. Family history. History of diabetes mellitus present in family members. In his father died at 92 years of age. There was hypertension in his mother, who again died at 90 years of age. There was no proven medical cause of death. It was natural death. And there is a history of diabetes in his second younger brother also. He is currently 60-year-old. And there was no family history of any renal diseases. Summarizing the history. So here is a 64-year-old male who was evaluated for visual disturbances at 58 years of age, found to have diabetes, hypertension, and cataract, underwent surgery for cataract, and was prescribed drugs for diabetes and hypertension, for which he was non-compliant to. And he had history of on and off pedal edema and frothuria, which was not evaluated, but then 1 year back, he was evaluated for giddiness, during which he was found to have renal dysfunction. He was medically managed for the same. 8 months back, he was admitted for probable acute coronary syndrome and underwent a CABG during that admission. He developed worsening renal function during the admission and was initiated on hemodialysis, and he remained dialysis dependent ever since. He also had weakness of both his lower limbs, affecting his ambulation, for which he is currently undergoing physiotherapy.
Complete diagnosis. At this point, what do you think?
So at this point, the patient has chronic kidney disease, stage 5D. Basic disease, probably diabetic nephropathy with microvascular complications of retinopathy and probable neuropathy, and macrovascular complication of coronary artery disease. Considering the paraparesis which occurred after the ICU admission, I'd also like to have a diagnosis of critical illness polyneuropathy at this point of time, and systemic hypertension and diabetes mellitus. And he had an intercurrent illness. He had an intercurrent illness of acute on chronic kidney disease during admission, which can be due to differentials.
Right. I didn't get any history suggest of autonomic neuropathy. What questions did you ask him regarding autonomic neuropathy?
So he did not have any bowel or bladder disturbances. I said he was continent. He assured continence and that he was not able to pass.
No.
But then we could not assess the giddiness because he was not able to ambulate properly, so could not assess giddiness.
Anything else?
And there was no history of any vomiting or bloating sensation for him.
Okay. In a male, you must also ask for
Yes,
erectile
sir.
dysfunction.
Actually, there was a history of erectile dysfunction from 58 years of age.
If you mentioned that, you could also include autonomic neuropathy as one of the complications.
He's having diffuse atherosclerotic vascular disease, right?
Yes,
so
sir.
you expect claudication. You have asked for claudication?
Yes, sir. I asked for claudication, but he said he had numbness of his left foot while walking, but not aggravating with walking, or he doesn't need to take rest during walking also. It was previously, not after this.
Right. So do you think a critical care illness neuropathy could persist for 7 months now? 7 months?
Usually it starts to recover weeks, from weeks to months it can recover, but again around 50% of the people can have residual weakness there, but not severe enough like to cause complete problems with ambulation.
Right. So would you think that this neurological illness is related to the diabetes itself?
Yes, sir. It can be. It can
Yeah,
very well
so I
be.
think that should be coming in first before you consider critical illness.
Yes, sir. In microvascular complications, retinopathy and neuropathy.
Okay. You mentioned that he is on weekly thrice dialysis. You mentioned about interdialytic weight gain and residual urine output. Anything else would you ask regarding the dialysis? You mentioned vaccinations also.
Yes,
you
sir.
said he is not aware.
No history of transfusions.
Anything else? How do you assess somebody who's adequately dialyzed? You sit in the OP and you see somebody.
Breathlessness before the day of dialysis.
Right.
Emergency admissions.
Right, emergencies. Okay. Anything else? Therefore, what is the first thing that gets better when you start dialysis?
Appetite.
Yeah, very important. So appetite, good sleep, and the energy levels are better when somebody is adequately dialyzed. So I think that you should mention. And regarding the vaccinations, what vaccination do you recommend?
For a dialysis patient, we recommend hepatitis B vaccination.
What schedule?
It's like the double dose vaccination, 40 micrograms. It can be given 0, 1, 2, 6, four doses.
Any other vaccine?
Annual influenza vaccination and pneumococcal vaccination.
What vaccines?
First, we have to give pneumococcal conjugate vaccine, following which, after 8 weeks, we can give pneumococcal polysaccharide vaccine, PPSV23, and every 5 years, we can give a booster dose of the same.
Other vaccines? So planning a transplant sometime?
COVID, but then
Would you consider giving varicella vaccine?
varicella vaccination also has to be. So
Yeah.
ideally, it should be done before transplant because it's a live vaccine. So
So when will you complete all these vaccinations?
if it's a live vaccine, at least 1 month before the transplant has to be completed, sir.
Any special precautions you take when a diabetic is getting dialyzed?
Yes, sir. First important thing is he might have autonomic neuropathy, so can have intradialytic events like hypertension or hypotension. That has to be addressed. And then they might have increased propensity to myocardial stunning also. So that has to be taken into account.
Okay.
And they can
How will you take care of myocardial stunning? How you identify myocardial stunning first of all? Then how you
hypotension,
take care of-
intradialytic hypotension, sir.
Intradiabetic hypertension can be of lot of causes.
Lot of
no?
causes.
Then how you pick up myocardial stunning in that patient? Did you find any unnatural in this case history from 2018 to 23? We had trauma reached severe CKD, and in 2024 in the acute coronary after CABG he had a severe renal failure which didn't recover.
Yes, sir.
So what are the possibilities of AKI in this setting?
Yes, sir.
Post cardiac surgery AKI.
Post cardiac surgery,
How you risk assess somebody sending a consultation to you? Yeah. Somebody is asking a consultation to you. Patient in ICU, we are going for a CABG. So how you assess this patient? Take it this patient. The patient you already seen.
yes, sir. This
So how
patient,
you assess?
this patient's baseline creatinine is elevated already. So for CABG, they'll go do a coronary angiogram initially. So he has a risk of contrast-induced AKI also. And during the time of CABG, due to cross-clamping of aorta, he can land up with atheroembolic renal artery disease also. And he might be requiring inotropes during his post-surgical time, where there can be hypotension, which can worsen his renal function. And he can be given drugs like statins, which can cause high-dose statins, which can cause rhabdomyolysis and cause AKI.
So what what would be your consultant opinion? They're asking for a fitness for CABG in this particular patient. So how you assess the renal status and then write what are the precautions as a surgeon to take or a cardiologist to take before going ahead for surgery?
Sir,
Called for to prevent a AKI event, right?
Sir, at this point of time, CABG takes the upper hand. So there is no contraindication to CABG. So we have to proceed with the surgery. But then we should make sure that the patient has adequate inotropic support and his mean arterial pressure doesn't fall too much post-surgery. And during contrast, at this point of time, the patient's urine output was pretty unclear, sir, because he didn't notice when he started to have reduced urine output. So maybe with reduced urine...
Are you aware about any risk scoring strategy for posting for CABG surgery in case of renal failure? Any risk scores are available to assess the risk of post-cardiac surgery AKI? Are you aware about any risk score for angiogram or angioplasty in a case of chronic kidney disease?
So contrast-induced AKI scoring is...
No. Is there any risk score so you can certify that there is a risk of this much, so many percent of AKI or dialysis requiring AKI? Is there any score aware of?
Yes, sir, there is a named score.
For surgery, CABG?
CABG, I'm not sure, sir.
So if this is a case of arterioembolic ARF, what are the clinical clues that this is a case of arterioembolic ARF and how you manage that arterioembolic ARF?
So arterioembolic ARF, usually it can be either spontaneous or it can be after any particular surgeries or endovascular procedures. So spontaneous is pretty less. When the patient is having so much of atherosclerotic burden, can happen spontaneously. Otherwise, it can happen after any procedure. Usually, there will be a slowly progressive renal impairment, which starts to happen a week or later the procedure. And there will usually be non-recovery of renal function, sir. It will cause dialysis recurring AKI. It's a downhill course it will have. And there can be peripheral signs like livedo reticularis or eosinophiliuria, which can be present.
What will the biopsy show?
The biopsy, the pathognomic finding is the presence of cholesterol clefts, sir. So,
what are they?
Cholesterol clefts are empty spaces in the arteries, which are actually where the cholesterol emboli used to be there, but then it got carried away during the processing of the specimen.
The alcohol dissolves that. Right. In 2023, he came with giddiness.
Yes, sir.
So what do you think was the cause of that giddiness?
He was found to have increased blood sugar levels, and it can be, he was having hypertension also. So those per se can cause giddiness, or it can be a simple manifestation of TIA also.
Okay. Anything else?
Or it can be a manifestation of autonomic neuropathy, postural hypotension.
Right. Anything else? This patient had a high sugar at that time.
Yes, sir.
It could also be hypoglycemia.
Hypoglycemia.
Because his creatinine was already 3. So why is there hypoglycemia when the renal failure sets in?
Sir, kidney is responsible for metabolism of around 40% of the insulin. So when there is kidney failure, that portion of the insulin's half-life will be prolonged.
Right.
So,
Right.
and gluconeogenesis happening in the kidney is also falling down with the...
How much of gluconeogenesis takes place in the kidney? What percent? Anybody else can answer? What percentage of gluconeogenesis takes place in the kidney? 30%. Okay, right. Okay. Fine. Any other reason why hypoglycemia happens? Hypoglycemia. Any other reason why it happens?
The patient can be preferred sulfonylureas
Right.
during
So
the...
half-life of these drugs would get prolonged. Okay.
So can we go ahead with the examination
Yes, sir.
specific to the case?
Okay, sir. Yes, sir. So after obtaining the patient's consent, he was examined. Patient was undergoing hemodialysis at the time of examination. Patient is conscious and he is comfortable in his supine position. So head to foot examination, there was presence of bilateral pseudophakia. I'll tell the positive findings. Bilateral pseudophakia, right IJV tunnel catheter in situ and functioning well. There was CABG midline sternotomy scar which was present. There was no pedal edema. A linear scar was present in the medial aspect of his right leg. The left RC fistula was functioning. There was continuous thrill. Skin over the fistula was normal. Arm elevation test, there was collapsibility of fistula, and pulse augmentation was positive. It was not yet cannulated, yet to be cannulated. His pre-dialysis weight was documented to be 56 kg. Height I could not measure, sir.
That's all inspection. Inspection. Examination over?
No, sir, this is head to foot examination.
Okay, right.
Vitals. Pulse rate was 102 per minute, which was regular in rhythm, normal volume, no special character, felt in all peripheral palpable vessels, no carotid bruit, no radioradial or radiofemoral delay. Blood pressure was measured in his right upper limb. It was 140 over 80 millimeters of mercury in the supine position. I could not test for orthostatic hypotension. Right and respiratory rate was around 18 per minute, abdominal thoracic type. The patient was afebrile. Systemic examination. CVS, heart rate was around 100 per minute. There was no murmurs. S1, S2 was present.
Muscle wasting? Muscle wasting? Because he was sitting for long, right? Is paraplegic?
Yes, sir. Actually, his bulk CNS examination.
Oh, it will come to CNS. Okay, right.
The skin manifestations also.
Yeah.
Skin
He was not having any skin manifestations other than the scars, sir.
What would you look for?
So it can be either due to CKD or it can be due to diabetes. So diabetes can have acanthosis nigricans as a manifestation of insulin resistance, or bullous diabeticorum, necrobiosis lipoidica diabeticorum, or scleredema can be there.
Anything else more common?
Folliculitis.
Have you heard of Krail's disease? Krail's disease.
You mentioned about Krail's disease, right?
No, sir.
Anything else?
Acquired perforating dermatosis.
Yeah,
Right. Anything else? Anything else?
Xerosis.
Yeah, he can also tell you whether he's been adequately dialyzed. Itch marks, xerosis, all these can tell you. Anything in the nails you look for?
Half and half nails or white
Yeah.
nails, murkiest lines.
Right. Okay.
In respiratory system, normal vesicular breath sounds heard in all lung fields. There was no added sound. Per abdomen inspection, skin over the abdomen was normal. All quadrants move equally with respiration. There was no scars or sinuses in his abdomen. The patient was wearing diaper and did not consent for examination of external genitalia. Palpation, soft and non-tender abdomen. There was no organomegaly which was present. Percussion, there was no fluid thrill. I could not do shifting dullness. Auscultation, bowel sounds were normal. There was no renal bruit. Coming to CNS examination, the higher mental functions were normal. Cranial nerve examination, normal. I specifically want to mention about optic nerve. Light reflex, it was present in both the eyes, normal, both direct and indirect light reflex. And cranial nerves of extraocular movement. Extraocular movements were full and free. There were no restrictions. And fundus finding, bilateral retina was able to find dot and blot hemorrhages, silver wiring, and AV nipping. Optic disc was normal. So suggestive of non-proliferative diabetic retinopathy with hypertensive retinopathy. Other cranial nerves normal. Sensory system, fine touch was impaired in both his lower limbs, whereas crude touch was normal, and the impairment was much higher below the knees. And pain, both superficial and deep pain, he was able to perceive. Temperature, I couldn't assess. Vibration, timed vibration sense was reduced below the knee. Motor system, bulk was equal on both upper limbs and lower limbs, but there was obvious wasting of his lower limbs. Power, upper limb, on all the muscle groups, it was 4 minus by 5 on both sides, whereas in lower limb, it was 2 by 5 on both sides, on all the muscle groups. Reflexes, biceps and triceps, 1 plus in both the sides. Supinator, I could not elicit. Knee jerk and ankle jerk on both sides, it was negative. And plantar was flexor on both sides. There was no spinal tenderness or spinal deformity, no neck stiffness, gait not assessed.
So proceed. You agree with the diagnosis that you gave initially? Anything else you want to add here?
Yes, sir. Based on this, I was able to confirm that there was sensory and motor neuropathy which was present in this patient.
Right. You still stick to critical care illness neuropathy, or think it's diabetic polyneuropathy?
The first DD will be diabetic polyneuropathy, sir. Sensory motor polyneuropathy.
Oh.
Second thing, still a remote possibility is critical illness, since there is acute onset of weakness which was after CABG, because he said he was walking to the hospital at the time of chest pain and then he had a sudden deterioration. So I'd still like to keep it as a second differential.
All his peripheral pulses were
Yes, sir.
palpable.
Yes, sir. Dorsalis pedis, posterior tibial,
Everyone
popliteal,
is palpable.
carotids, everything was palpable.
Okay, before planning for an AV fistula in particular patient, what would you like to know about his vascular system?
Whether there is presence of atherosclerosis or adequate collaterals are present in his
How do you
distal
check
foramen.
for, yeah.
Allen's test can be done, sir.
You
To
know
check.
how to do
Yes,
it?
sir.
Yeah, okay. Other than any investigation you would like to do?
Doppler,
Planning for AVF.
Doppler mapping of his limbs.
Other than that, would you like to have any X-ray of any particular area? It's a recommendation actually now.
To check for calcifications of
Yeah, which X-ray you take for vascular calcification? In general, you see a CKD patient, you want to know whether there is vascular calcification, you take a particular way of X-ray. What is that X-ray?
chest X-rays.
Of vascular calcification. Is there any recommendation for that? Do you assess CKD MBD for this patient before going for AVF? CKD MBD.
Yes, sir.
What all things you look for in CKD MBD?
Basic blood investigations, calcium, phosphorus, IPTH, vitamin D.
Did you review his
And then DEXA.
prescription? Did you review his prescription?
No, sir. He
No,
was
you're
not having prescription.
Not having his prescription.
He came for his dialysis, routine dialysis only. Nothing was
Okay.
okay.
Suppose you had seen him when he came for that defective vision way back in 2018. What steps would you have undertaken?
Sir, first thing is, at that point of time, it was not sure whether his kidneys were evaluated or not.
No, what would you do?
Blurring of vision, we should do a fundoscopy to screen for retinopathy.
Right.
He was perhaps told that he had some issues due to his hypertension and diabetes, but then he was not following up for 5 years after that.
That's what I'm asking. Suppose you had seen him at 2018 and
Yes,
he
sir.
was very compliant with whatever you said. What
Then
steps would you
We have to do a urine analysis, urine screening for diabetic nephropathy,
No,
sir.
he was freshly detected diabetes, so first thing you will do is control his diabetes well,
Yes,
isn't
sir.
it? So what drugs would you use for him at that time? We'll assume that his creatinine was normal at that time, 2018.
So creatinine was normal and the patient is having diabetic microvascular changes. You can go ahead with metformin as the first choice. So his GFR is good, quite good. So we can go ahead with metformin and see if it is getting controlled. So if it is not controlled, then we can go ahead with SGLT2 inhibitors.
So now a combination therapy is suggested, isn't it?
Yes, sir.
Okay.
So SGLT2 inhibitors and see if it gets controlled with both these two. If not, then we can go for second line drugs like GLP-1 analogs.
What else would you advise?
And then we can look for proteinuria at that point of time. If proteinuria is present, add on with ACE inhibition, RAS inhibition.
Right.
And we can see if maximal tolerated dose, if he gets okay with that, fine, or else we can go for next.
Fine. What else? What else?
Non-steroidal mineralocorticoid receptor antagonists can be given, Finrenone.
Okay. Much more simple things that you can do.
He should be started on statins to reduce
You have to
ASCVD risk.
control his sugar, so you would advise self-monitoring of blood glucose. These are
Yes, sir.
the things that you would encourage the patient, involve the patient in his own care, right? Home monitoring of blood pressure. So these are the important things that will help prevent all these complications. So just prescribing drugs alone would not suffice, right? You would encourage him to have physical activity of how much?
150 minutes per week,
Ah.
spread over at least 5 days.
So moderate
30
to-
minutes of moderate intensity, moderate to severe intensity work.
intensity. So these are simple things that you must do. You cannot start somebody on Finrenone on at their diagnosis of diabetes, isn't it?
Yes, sir.
Right?
When you prescribe ARB, what would be your advice to the patient? Or otherwise, would you advise any sick day rule for a patient taking ARB or anything? Because you are optimizing him on the maximum dose of ARB. So what would you advise?
Yes, sir. Ideally, if the patient is having any symptoms, it is better to come and consult with us and stop the drug on that day, because if there is any...
You have given, I am the patient, you have given me losartan 50 milligram twice daily. I am asking doctor what precaution I should take.
So if you have any giddiness, postural giddiness, you have to home monitor BP, or if it is not possible, come back to... Then after
so you are only interested in coming back because you get money, right? Okay. Right. Other than that?
So we have to check for his potassium levels,
Then?
his creatinine levels.
I have a periarthritis shoulder. I went to an orthopedician.
Avoid NSAID use.
I have a diarrhea. What did I do?
You have
I
to
have a
hydrate
high-grade fever.
hydrate adequately, adequate hydration.
This is very important, man. When you prescribe a drug which is actually interfering with the hemodynamics, you have to check. Otherwise, all patients will go to hemodialysis and then you will get a lot of money. Acute cardiorenal syndrome, would you consider in this patient when he was in ICU?
Yes, sir.
You would be considered.
It can be considered as a different. The stressor which caused acute on CKD, one of the DDs is CRS1.
How will you screen for coronary artery disease in a diabetic CKD?
CT coronary calcification score is there.
Straight away you will go for CT coronary angiogram, or how will you screen?
Basic ECG has to be taken.
Right,
Lipid profile,
right.
an echocardiogram.
Yes. Suppose he's a younger individual and he's coming to you for a transplant. So how will you evaluate? Let's say he's 50 years old and he's coming to you for a transplant. He has no other complications. You have to screen him for
If the
coronary
patient is
artery.
asymptomatic,
He's asymptomatic, but he's a diabetic, so I'm worried.
so if the baseline ECG is normal without any symptoms, we need not screen the patient, sir.
How many diabetics you have transplanted?
Many people also.
If you ask people who have transplanted diabetics, most of them will tell you that post-operatively 50% of patients would have some sort of coronary artery disease manifestations, straight from a myocardial infarction to other complications. Right. So what else can you do? Suppose your ECG and echo are normal, does it mean a
Stress
50-year-old
testing.
diabetic has got normal coronaries, normal heart?
Stress testing can be done, sir.
What stress testing?
If the patient is ambulant, then we can go for treadmill testing. If the patient is not ambulant, then we can go for either myocardial perfusion scanning or dobutamine stress test.
Right. So these are simple ways of doing. So is it mandatory that it should be done, or taking care of this has improved outcomes?
No, sir. No,
What
there
is
is
the-
no
what is it?
improvement in patients who...
What is the evidence for that? Any evidence to say
Yes.
that revascularization is not really, it doesn't really matter? Anybody else can say? Ischemia CKD trial, I heard that answer. Okay, so please read about the ischemia CKD trial,
Yes, sir.
which did not show much evidence that revascularization has a more favorable outcome compared to non-revascularization. Suppose you're planning transplant for this patient. Let's say he doesn't have any of these complications you mentioned. What are the other areas that you will concentrate on? One is to look at the heart, right? Okay.
Vasculature for anastomosis.
Right. So what would you do?
Ideal to go with the CT angiography of his vessels,
Which vessel?
iliac vessels,
Iliac vessels. Okay. Right.
and check for a calcification.
Okay. Anything else you would consider very, very important before you transplant?
He's a type 2 diabetic, so we'll go ahead only with isolated kidney transplant.
That's fine. Anything else? Transplant on diabetic is not very easy. Any other area that has to be looked into? Bladder, yeah, very important. Okay.
Yes, sir.
Just
Yes.
because he has no complaint
No.
doesn't mean your bladder is normal. Right? How will you evaluate the bladder? How will you evaluate the bladder?
Sir, if the patient is not having any symptoms, we can just go ahead with USG and see his post-void residual urine.
Right,
So if
right.
there is no post-void residual urine and he is able to pass urine freely, we can go ahead. But if there is significant post-void residual urine, we have to go ahead with a uroflowmetry and see the maximum flow of urine. If it is reduced, then we have to go ahead with
Patient
urodynamics.
does not have any residual renal function. How you assess post-void residual urine?
Then we have
He's
to
on MHD, right?
so we have to do a VCU,
What is that?
voiding cystourethrogram.
Mm.
So we put contrast into his bladder, see the maximum bladder capacity, and see if he is able to void properly, and see if there is any reflux in his reflux back into the kidneys also.
What is the other advantage of this MCU? If at all you do an MCU, what is the other advantage that you can see something? Suppose there is a neurogenic component, you can see it on the MCU.
Yes. The bladder abnormalities can be
You
seen.
can have diverticular,
Yes, sir.
you can have the fertile appearance. So that will give you an idea about how the bladder functions are. And ideally, if there is a residual urine, you must look at urodynamic studies also. Because this bladder is a very important area, and complications related to urinary tract infections are more in diabetic transplants. So unless you sort it out, transplanting is not going to be that very easy.
How you preserve the residual renal function in this patient? Patient is having around 400 to 500 output. You want to preserve it over years. How you preserve it?
For this patient or for this
Any patient
Okay.
on MHD.
First one is to avoid intradialytic hypertension.
How you avoid intradialytic hypertension?
We have to check for the intradialytic weight gain of the patient. So if there is more intradialytic weight gain, then we can increase the frequency of the dialysis so that the ultrafiltration rate is less. That will reduce his.
Any trial which has shown that there is cardiovascular benefit by increasing the duration or frequency of dialysis? You practice evidence-based medicine, right? So you will started increasing dialysis because he is not compliant, or any trial which looked at whether increasing the frequency or duration helps in CV outcome or. Okay, what are the other strategies you look for?
Give adequate diuretics. The patient is having urine output, so give diuretics.
How much diuretic you give?
He is a chronic kidney disease patient, so
Yeah.
Usual dose might not be sufficient.
What is the dose? That's what I'm asking. You are a nephrologist, no? I am coming to you for treatment. You are asking me what is it required dose?
What maximum diuretic?
200 milligrams of Lasix.
So next week I come with the loss of hearing.
No, that's the maximum.
So what do you do? I am telling doctor you prescribe diuretic. Now I can't hear anything. You damage my both the ears.
80 milligrams, patient can be started on 40 milligrams BD.
Do any study which looked at ototoxicity in CKD, advanced CKD, of the use of diuretics? Any other than diuretic, what is the most important drug?
NSAID should be avoided also.
Any other drug which is supposed to be very useful in preserving residual renal function, which we commonly prescribe?
AC inhibition.
Yeah, please.
Yes,
Yeah. Then what are other strategies? Is it not important to preserve residual renal function?
Yes, sir, definitely.
Yeah, it is already shown in many studies that patients who have survival have good residual renal function. So it's very important. Okay.
Why it's important to preserve the residual?
So because dialysis can only remove the small solutes, whereas even little amount of residual urine output can remove all other unknown middle molecules.
Right.
So that can
this
help.
polyneuropathy is because of
The middle molecules.
clearance. So which modality of therapy is better for middle molecule clearance?
Hemodiafiltration.
Any study which looked at hemodiafiltration versus hemodialysis in 5D patients, which says definitely there is an improvement in.
Convince trials.
What was the dose recommended in that? How do you
20 liters.
dose the hemodiafiltration dose?
The effluent dose, sir.
Effluent dose or?
Okay, fine. Suppose this patient has heart failure. Post CABG, things did not work out well. He has heart failure. What drugs would you consider giving? The cardiologist has written a lot of drugs. As a nephrologist, you have reservations about certain drugs. So what are the various drugs used for heart failure in this patient? And how useful or what doses will you give? How will you adjust the dose in somebody with renal failure?
Spironolactone.
You're going to give spironolactone. He's got CKD 5D. No?
Sacubitril valsartan.
Yeah. So can it be used? Valsartan sacubitril can be used.
Yes, sir.
You have to modify the dose in CKD. Any other drugs, heart failure drugs? Well, this is the combination that you would see. If he doesn't have coronary artery disease, he's going to have heart failure. Yeah. Any other drugs? You mentioned something about fentanyl earlier.
Yes, sir.
In what patients would you use fentanyl?
In patients with heart failure, with
Yeah, one is heart failure. Other is suppose you're seeing a diabetic patient in your OP. So which is a group of patient you will start on fentanyl? What will you monitor?
if the patient continues to have persistent proteinuria despite AC inhibition, then we can go for fenrinone, sir.
So what dose would you start? What is the GFR
60.
above which you will start or below which you wouldn't start?
Below 60 it's 10 mg, above 60 it's 20 mg, sir.
Okay. So 60 means, below 60 means what? What is the lower limit of cutoff? That is important.
45, sir.
Anybody else?
30 or 40. 20.
25. Okay. Okay, fine. So how will you monitor fentanyl?
So again, similar to spironolactone, we have to check for hyperkalemia, presence of hyperkalemia. So 2 weeks later, we can check for presence of hyperkalemia.
Right. If there is hyperkalemia, what would you do?
So don't change the drug immediately. If it is more than 6, then we can consider withholding drug for some time. But if it is below 6, 5.5 to 6, then we can go ahead with other measures like increasing soda bicarbonate or giving potassium binders, dietary restriction of potassium, or adding diuretics.
Right.
The patient is having
So
urine
you
output.
can reduce the dose of fentanyl and restart after the hyperkalemia gets better. Okay. So in your glycemic control, you said you will start with metformin and then add SGLT2 inhibitor. And if with this the sugar is not getting controlled, what else would you add?
GLP-1 analogs.
GLP-1. Why? Why do you want to use that?
GLP-1 analog, again, it's proven to have cardiovascular benefits also.
It doesn't have any renal benefit?
Yes, sir, it has.
Ah.
The flow trial, which was
So what did
done
the flow trial
recently.
show? What was it? What
flow
did-
trial showed it actually saw the primary outcome of composite renal outcomes.
Yes,
Sir.
yes.
So incidence of kidney failure or 50% reduction in GFR are dead due to renal failure. And they randomized the people with lower GFR of 25 till 25. As actually they had 2 groups with difference in urine ACR and
So what is the
GFR.
major flaw in the flow trial? The criticism of the flow trial?
Most of the people were not on SGLT2 inhibitors in this person. Only few % had SGLT2 inhibitors because the recruiting of the patient started before it became a recommendation.
We'll
So
come back to the patient again. I sent a neuro consult for this patient and neurologist said it is not neuropathy, it is proximal muscle weakness in a CKD patient. It is your burden. What would be your thought? It is a proximal myopathy. He is not getting up because of its proximal myopathy. What is your thought on that?
can be secondary to uremic sarcopenia.
Other than that, his PTH is 2,500.
Sir?
Parathyroid hormone is 2,500. Can hyperparathyroidism cause
Cause muscle weakness. Yes, sir, it can cause.
Can. And how you treat? If he is having a PTH of 2,500, he cannot get up from his chair, how you treat?
So have a look at what bone turnover he is having.
How do you look at it?
High bone turnover.
How you look at it?
PTH level is high, so
I already told, no?
is high
PTH is
high bone turnover. So we have to have a look at calcium and phosphorus also.
Yeah.
What is the calcium and phosphorus? So then we can go ahead.
Calcium is 7 and phosphorus is 8.
Phosphate is 8. We have to go ahead with bisphosphonates.
Why? Why bisphosphonates? He can't get up from his chair, and he comes to a nephrologist with a PTH of 2,500. You want to send him for a DEXA scan. Again, you want some money from that. Right. What is the recommendation for DEXA scan in a CKD 5D patient with MBD? Does KDIGO recommend DEXA scan for all patients with CKD MBD?
It's not for all patients.
Then for which patient? How are you going to treat this patient? I'm at your disposal. I'm the patient.
So in such a situation, the idea is to control the phosphorus first, right? So now that the PTH is high and the calcium is low, look at the corrected calcium. Control the phosphorus first, because if you're going to give calcium, the calcium phosphorus product is going to go up very high, which will lead to metastatic calcification of vessels, or calcific arteriolopathy, which will again affect your vascular access, right? So the idea is to reduce the phosphorus first, either with calcium-based phosphate binders or non-calcium-based phosphate binders, and then address the calcium. So the PTH is high and the calcium is low. The ideal thing to do will be to give calcitriol, which will suppress the PTH at the same time increase the calcium, right? This is one. Other investigation that can be found in specific centers that will help you is to do the bone alkaline phosphatase, the bone specific alkaline phosphatase. So that will give you some clue as to how MBD can be taken. In diabetic patients, what sort of MBD happens?
Adynamic bone disease.
Adynamic bone disease. So how will you recognize adynamic bone disease?
It's low PTH levels.
No, clinically. When will you suspect? What symptom he'll come with?
Bone pain.
Bone pains may be quite severe. What group of other patients have adynamic bone disease?
Aluminium toxicity.
Aluminum is not a big issue these days with good RO plants. What is the other group of patients who have adynamic? Patients on peritoneal dialysis. Okay. So these are important things in a diabetic. When we spoke about special problems of diabetics on dialysis, first and foremost is the vascular access, because that is where all your problem starts. And you mentioned this patient got a radiocephalic fistula.
Yes, sir. It was
Right.
done 1
Actually,
month back.
What has been given to us is that's a BVF that has been created. So
He was
probably
having
could look at it again.
forearm RCC.
Yeah, so it is more of a two-stage procedure that they are taking. Would you add the glucose in the dialysate? Normally, does the dialysate contain glucose?
No, sir.
It doesn't contain glucose. So in a diabetic, would you consider adding glucose in the dialysate?
Yes, sir. To prevent hypoglycemia, glucose can be added to the dialysate.
So how will you add glucose to the dialysate? I'm giving you 25% dextrose ampules.
Sir,
There is
The
a
con-
10-liter acid can.
100 mg per.
Normally, why does the dialysate does not contain glucose? You said it doesn't contain glucose. So why it doesn't contain glucose? Anybody else?
GD.
Yeah, bacterial contamination. That will ferment, So the dialysate will get contaminated. So you will go and look up how much of dextrose will you add.
So to calculate to get the final product to 100 mg per deciliter concentration.
Right. So that has to be looked into and then calculated. And as Noble was mentioning, have a relook at the prescription. Okay, because there could be drug interactions. There could be some abnormalities, prescription errors in the calcium phosphorus area, that particular area where things are not probably put it the right way. So he's on dual antiplatelets now?
Probably he should
Most
be on.
probably he must be on dual antiplatelets.
What ESA is erythropoietin or W-protein for this scan?
He was not able to tell, but he says it's taken after every dialysis. He's taking it in his abdomen
Do you think any
subcutaneously.
precaution you should take when you prescribe a erythropoietin or erythropoietin stimulating agents for
It's a-
diffuse atherosclerotic vascular disease?
So there's a higher risk of thrombotic manifestations. So
what do you do?
keep the first replete the iron, then keep the target hemoglobin to less than 11. Like don't overtreat. Higher the dose, then higher the.
Problem with the vascular complication. Do you dose HIF inhibitors
Yes, sir.
used in this particular patient? Is it
P-
contraindicated or relative contraindicated, or you can safely use?
It's not safe, sir.
It is absolutely contraindicated this patient, relatively contraindicated, you can safely use. Take one.
Absolutely contraindicated.
Absolutely
sir.
contraindicated. Okay.
Yeah. That is taking an injection after every dialysis means it's not a Darby or
Probably
Sera. So
erythropoietin.
he's taking only the regular erythropoietin. And very important to keep the target hemoglobin hematocrit low. Why? Why is it so? Why do you want to keep the target hemoglobin low?
Sir, this is a patient with severe systemic manifestation, other organ manifestation. So we can keep the hemoglobin target low because higher the hemoglobin.
Any other evidence to say that this hemoglobin is suffice?
Do you remember any study which looked at target hemoglobin and said that, oh, above this is dangerous?
This is enough. Yeah.
Yes, sir.
Yeah. Anybody else? Create, yeah. Choir, yeah. So please, these are very landmark trials that showed that a high hemoglobin is really not required. Okay.
Thank you.
So well done. Certain areas you just have to look into practical aspects and concentrate.